welcome to everybody tonight. This is going to be a somewhat casual and conversational talk tonight. After each section, I'm going to take a pause and see if anybody in the audience has any questions or comments, and I'm going to repeat them for the sake of the studio audience or the video feed. Just going to start with a quick little joke. Dr. Brown says to his patient, I've done a lot of work here. I've consulted with my colleagues. We've done a lot of blood work. We've done some imaging. We've done a lot of thinking about your case. And we've come to the conclusion that you definitely have high blood pressure and amnesia. To which the patient says, well, thank God I don't have high blood pressure. All right, let's start with age-related memory loss. I'm primarily a clinician, so I'm in my office, and it's very common to see folks come in who 60s, 70s, 80s, maybe a little younger, maybe a little older, who are worried about their memory. And common complaints. I know the name of that person that I saw at the mall. I can't remember where I put my keys. I know the name, but I can't remember what the name is. I know that name of that movie star, but it's just not coming to me. And lo and behold, an hour later or so, the name will pop back into the heads of the people. And that's kind of like, the way I look at it is the information is stored in the brain in a drawer, for example, and the drawer needs a little bit of oiling and it comes back out. And those type of examples, when I hear that from people, I really think of age-related memory loss. Age-related memory loss. And that's normal. As we age, unfortunately, we know that most things go downhill. Hearing, vision, balance, and memory is no exception. So a lot of people that come in worried about their memory really just have age-related memory loss. I want to reassure folks about that. However, there are obviously more serious things out there. And before I get into them, I just want to talk about some interventions that are possible, lifestyle interventions that are possible, that may exert some protective effect on the brain in terms of reducing the likelihood or maybe prolonging the age at which the more serious issues arise. So it sounds a little bit like common sense, but this has actually been studied, proven, and there's a lot of data about it. And first of all, we're talking about cognitive stimulation. Think of the brain as a muscle. It's not a muscle, but think of it as a muscle, and you have to exercise it. And we're talking about folks that exercise routinely throughout their lifetime, make it a lifestyle. And that's excellent for brain health. Social stimulation, physical activity. A lot of information and a lot of data about physical activity and routine exercise. These are important lifestyle adaptations to exert a protective effect on your brain. Healthy diet. A lot of questions about diet. What can people do throughout their life? The Mediterranean diet. That's a diet where there's a lot of fish, a lot of oil, a lot of nuts, a lot of protein. That's sort of an overview. And that has a somewhat protective effect, as does anything that's good for cardiovascular health. So anything that's good for cardiovascular situation is also good for the brain. Finally, something called sleep hygiene. It's kind of a funny word, but basically it's saying if you're sleeping well during your lifetime, obviously people go through periods of time when they're not sleeping well, but generally speaking, if you're getting 6, 7, 8 hours a night, that's going to be healthy, and that's going to be helpful down the road. Then the last thing is avoiding traumatic brain injury. Okay, obviously there's events that we can't avoid. Things happen. But for example, you're not going to see me riding a motorcycle. You're not going to see me riding a bike without a helmet. You're not going to see me in a boxing match. Just common sense things that we need to do to protect our brain. And so these are things that we can do that aren't going to necessarily turn the tides of fate, but can exert somewhat of a protective effect on things worse than age-related memory loss. And we're going to get into those. I'm going to stop right here and see if anybody in the audience has any questions. The question is there a distinction between Alzheimer's disease and dementia? And it's an excellent question. I get it asked all the time. And I was planning to address it later, but since it came up now, I'll address it, and then I'll probably address it again. Basically, dementia is you know what, sir? Dementia is an umbrella category where things aren't going well. You're not functioning well. Things are going downhill. You're not independent anymore. And that can come from many different reasons. Vascular, such as stroke, Parkinson's disease can lead to that. So Alzheimer's disease is a specific pathology where there's plaques and tangles formed in the brain. This is a bird's eye view of the situation. And it can lead to cognitive deficits and cognitive decline. So it's a disease that can lead to dementia, and dementia being an umbrella category. I'll come back to that concept. The next category is called mild cognitive impairment. It sounds like a description, but it's actually a diagnosis. And mild cognitive impairment is, I would say, of concern. Okay, and this is when folks, somebody notices a change. There has to be a change in prior functioning, and prior thinking. So somebody used to have a good memory, an average memory, and now they don't. They're asking repeated questions, as an example. And somebody notices it. The patient themselves, I say patient because they may show up in my office, they notice the problem. Family members, friends, sometimes they're doctors, they're general practitioners, they're cardiologists, notice a change being the key word. And we focus a lot on memory because that's the, I would say, main and most prominent domain in which we see a problem, but there are other things that you can observe in somebody's thinking and perspective. And let's talk about what those are. Something called executive functioning, and that's a top-down approach to a task-oriented, to performing tasks in a goal-oriented behavior. So, for example, you're planning you need something to fix something in the sink. You have to make a plan. I have to go to the store. I have to buy a certain object. I have to do this. I have to do that. You're doing sequential planning and performing the tasks. That's something that's part of executive functioning. That's one example, but we use executive functioning every day in our lives. Other domains include visual spatial. So visual spatial, what do we see? How do we interpret objects? How do we navigate our environment? And can we do it well? And can we execute well? Finally, there's attention and behavior. If you see a behavioral change in a person, obviously you're looking for what's going on in their lives. Could they be depressed, and so on and so forth. But if there's a personality change, it might capture your attention, and it may be a clue. So we see something happening. There's some kind of a change, and it has to be significant in that if they come into the office, for example, we do what's called bedside testing in a neurology office. And bedside testing will include both a history. Before the bedside testing, it's a history from the patient, and also a corroborative source, somebody that knows the patient well and has seen them over time. We'll then go into bedside testing. I don't know, some of you may have had this before, mini mental status examination, Montreal cognitive assessment evaluation. These are a series of neuropsychological basic tasks and questions that we go through. And if somebody scores considerably below what they should for their education and age-matched controls, then we see a problem. So, for example, somebody may come in and they appear normal, just having a regular conversation, but there's somebody's noticed a change, and we go through an evaluation, and that person, I would say, well, gee, I think they should score a 29 or a 30 on a mini mental status exam. That would be normal. They scored a 24, a 25. I was able to pick up things on the evaluation that were surprising and were not immediately apparent by just having a friendly conversation. So there's some genuine objective evidence that there's an issue going on. But here's the key in mild cognitive impairment as opposed to dementia, which we're going to talk about. The key is that these folks who have mild cognitive impairment are still functioning on their own. They may have some problems, some minor problems. They may make some mistakes in writing a check or organizing something, but it's a small mistake. It's here or there. It's not consistent. But they may have to write a list when they go to the store, for example, but they can still get by. They're functioning on their own. And they can have an impairment in memory. They could have an impairment in visual spatial function. They could have an impairment in executive function, or more than one, actually. So the key here is that folks are still functioning independently. And as a clinician, we watch these folks to see if there's a decline over time. There's obviously been a change, and we want to see over time if there's been some sort of decline in their skill set and their abilities. We rule out reversible causes because sometimes mild cognitive impairment is sort of we call it a prodrome, kind of a preview or the very beginning of what will eventually be a dementia, which I'm going to talk about. But sometimes there are reversible causes when somebody is fuzzy and not the same as they always have been. And for example, depression, which I mentioned, is a big one. I've seen multiple times people that were treated for serious depression came back in and were bright and perky. So we have to be very, very careful about depression. There's medication effects. Very, very careful with medication effects. And sleep apnea, very common, sometimes underdiagnosed, and sometimes diagnosed, and folks don't like to wear the CPAP machine, very uncomfortable, and they don't do it. So these are reversible things that we could say, gee, let's approach these things and see if the person's cognition improves. And I've seen that happen at times. If we don't see any of these issues that I just discussed, we want to make sure that there's no evidence of trauma, previous trauma, strokes, and we rule out stroke by history, by neurological examination, and by imaging, such as MRI. And I also always look for signs of Parkinson's disease, because Parkinson's can have a cognitive decline component to it. So I'm looking holistically at the patient to see if there's any clues to any other organic process that may be going on. And we're going to get into the difference between mild cognitive impairment and dementia and the different subcategories of dementia in a minute. But I'm going to stop here and I'll field some questions from the audience. I'll be happy to do that, or any comments. So I'm going to paraphrase from this young lady. Her husband had some cognitive issues, and when he would be, I guess, tested in his doctor's office, can he remember certain items after 5 minutes? Does he know who the president or the vice president of the United States is? These are looking at fund of knowledge, right? I mean, even if you're not interested in politics, you hear the name Biden so much, It should be in there. It should be in there. And her husband would say to her afterward, if he didn't get the right answers, that he was nervous. He felt that he was being grilled. He was put on the spot, and that's why he didn't perform up to par. And I think it was a comment, but I think sort of embedded in that is also a question, which I'm going to interpret as, do I see that in my daily practice? Is that a thing? I would say this. It depends on the circumstance and on the individual. But by and large, if I'm dealing with, when I say I'm talking about any, competent neurologist. If I'm dealing with somebody that I have a suspicion that there's a process going on, those are usually what I would consider kind of excuses. I hate to say it that way because I'm very, very sympathetic to somebody feeling that they're not well. But I don't know. My opinion is if you don't know who the president is and if you can't remember a couple of things a couple of minutes later, probably not normal. So there are exceptions. But in the right setting, we have an intuition or a sense, and we, as clinicians, we go with that. There's also, so I'll move on, and I'd like to talk about dementia now. And you can think of things as a continuum sometimes. We have the normal aging process, we have mild cognitive impairment, which I spoke of, and then we have dementia. And I'm going to talk about how the word Alzheimer's disease fits in with dementia again, because it's a little bit of a tricky concept for folks. But before I do that, I want to tease out the difference for you folks between mild cognitive impairment and dementia. And in dementia, we have a lot of the same factors that we have in mild cognitive impairment, but there's more than one domain. So in mild cognitive impairment, it might strictly be memory. It might strictly be visual spatial. But in dementia, by definition, we have to have more than one domain. So it's going to be memory plus language, as an example. Now, ideally, as a clinician, we'd be able to trace back what was the presenting situation, how did it begin, and then other things evolved. But there's two domains, but most importantly, to use the word dementia, which is a scary word, to use the word dementia, there's some interference with the person's functioning. We say social or occupational functioning. A lot of folks, by the time they have a dementia or may not be working anymore, it's hard to say occupational, but the definition is social and occupational functioning. I look at it a little bit, is another way to look at it, and I look at it the following way. Can people do their activities of daily living? So activities of daily living, some folks may have heard that term before. That's what you do every day. You get dressed, you take a shower, you go to the bathroom, you make a sandwich. These are activities of daily living. And these things can be affected later on in a dementia, but they can be affected. When we're looking at a milder case, people can usually do those things early on, but somewhat higher level things that we call instrumental activities of daily living. The nomenclature isn't that important, but things like organizing your finances, things like organizing your medications, things like maybe doing the laundry, which takes a couple of steps. Those type of things. How about driving from point A to point B? You've been there many times. Are you getting lost? Can you get there? These are the kind of things that we start to see interference with. And by definition, there has to be some interference to qualify for the word dementia. Now, just to go over again some of the domains that can be affected. We did it once before, but I want to bring home the point. Memory, and we're talking often about short-term memory, or episodic memory, learning and recall of recent learned events. That's where you get into the repetition part of things. Language, production, and comprehension of speech, word finding, that can be affected. Visual spatial cognition. Are people getting lost? Can they recognize faces? That can be a problem. Can they recognize objects? That can be a problem. And again, executive functioning, and in that category would be impaired reasoning, judgment, and problem solving. And again, we look for also change in personality. Now, let's come back to this concept of Alzheimer's and dementia. Dementia is an umbrella category that fits a description of what I had spoken about. Alzheimer's disease is the most common reason for dementia in the elderly population. The most common reason for it in the elderly population. And I'm going to come back to the mechanism, the hypothesis of Alzheimer's disease in a moment. But think of Alzheimer's disease as a disease that can begin with mild cognitive impairment. It's actually the beginning of the symptomatic phase, but then evolve into dementia. Other reasons for dementia, and there is a myriad of reasons. Vascular dementia, in the older population, is the second most common type of dementia, and also folks sometimes have vascular and Alzheimer's pathology. So vascular strokes, vascular disease in the brain that's maybe not quite stroke, but similar to and reminiscent on imaging of lack of blood supply, not therefore oxygen to areas of the brain. There's something called Lewy body dementia. You've heard of that. And that's an interesting disease where someone develops a dementia and a Parkinson's-like appearance within 1 year of each other. There is Parkinson's disease dementia as well, which will develop later in Parkinson's disease. There's something called frontotemporal dementia, which can often affect folks younger, perhaps in their 60s, although it can come on later. And then there's a variety of dementias that, run the gamut. And I've seen many different types. Alcoholism can lead to a form of dementia. I trained in the AIDS era, HIV-related dementia, syphilis-related dementia. There's all types of things. I saw a world-famous boxer whose name I won't use when I was a resident, and he was 41 years old, and he didn't know his name, and he couldn't function at all. And we used to call that dementia pugilistica, and we now know it as chronic traumatic encephalopathy. And if anybody follows the NFL, you may have heard those terms. So it runs the gamut. But what I'm interested in is trying to provide hope for dementia, specifically Alzheimer's, because Alzheimer's is the biggie. It's the 800-pound gorilla in the room. And if we can affect that disease, then, or slow it down at least, then we can help a lot of people. I'm going to just talk briefly now about Alzheimer's disease pathology. What is Alzheimer's disease? So I'm going to give you one hypothesis. It's a well-accepted hypothesis, but it's just that, a hypothesis. We don't know for sure what it is and what causes it. But for purposes of our discussion, I'm going to simplify a little bit. And here's the prevailing amyloid hypothesis in relatively simplistic terms for the lay audience. Say my fist is a brain cell, and we have billions of brain cells. And say my index finger is a protein. It's like a flag sitting there. And it's a protein, and it's supposed to be there. And this is an amyloid protein, and it gets cleaved abnormally. for a variety of reasons and in a variety of ways. But it gets cleaved abnormally, the amyloid precursor protein. It then floats off in the brain. It has a different form than the regular amyloid protein, and it clumps together. It's sticky, and it forms plaques that coat a brain cell like barnacles. So you have this abnormal cleavage of the amyloid precursor protein. It becomes different amyloid forms, clumps, and forms plaques and barnacles on the cell. And what happens then downstream from that, there's another protein called tau, T-A-U, which is a microtubular transportation organelle within the cell, among other things. And that gets changed in a chemical fashion by virtue of what's going on in the outside of the brain. And when that tau changes, there's a whole cascade of events that occur, which is beyond the scope of our discussion. And let's leave it at this. The brain cells are rendered less functional, and the communication between the brain cells and different parts of the brain start to break down. So that's the amyloid hypothesis. There are other hypotheses. There are other hypotheses. This may be proven wrong in some way, shape, or form. We know that there's an association with this abnormal amyloid protein, but is it the initial reason, or is it an epiphenomenon? Is it something we're just seeing? These are questions that need to be answered, but we don't have all the answers right now. So before I go on, I'm going to stop right there. I hope I was able to explain some of the terminology that we use, because I know it can be confusing. Any questions or comments, sir? So the question from this gentleman is, he's correctly commented that there are many paths toward dementia, and he'd like to know how big a slice of the pie is Alzheimer's dementia among all the dementias. So there's 6 million people in the United States with Alzheimer's disease. I don't know the percentage off the top of my head, but I will say among folks that are 65 and above, it is an educated guess without referring to the data, 50%, 60%, in that ballpark. It may even be higher. So it's the big gorilla in the room. But vascular dementia is the other one. That's the big gorilla in the room. And oftentimes folks have two pathologies. We learn in medical school and in training that we're always looking to use Occam's razor. Occam's razor is, how do we explain something? What's the simplest explanation? There's one thing that's causing everything. And as it's a good exercise, but it doesn't always hold true, especially as the body and the brain age. So there's allowed to be more than one thing going on. Any other questions? When I was training, we'll say the late 90s, early 2000s, we didn't have any what we'll call biomarkers. Biomarkers is something you can look at and see and say, aha, that's here. This is supportive of an Alzheimer's disease diagnosis. And you're quite right. The official diagnosis was based on an anatomical slide, pathological slide of the brain, identifying various abnormal structures consistent with Alzheimer's pathology. There's been a lot of very, very exciting movement in the field where biomarkers have been developed that can support a clinician's, or for that matter, family members' suspicion that a person has Alzheimer's dementia. So, for example, we're now able to do a PET scan. Most people know PET scan through, if they have cancer, for example, it's a nuclear scan. You get injected with a radioisotope. This is something that's radioactive. It will bind with A, B, or C, whatever you design it to bind with. And then in a PET scan, it lights up, and you can see it there. Well, they were able to design a PET amyloid scan. where there is an isotope that's injected that will get into the brain. Not always easy to get into the brain because there's a lot of barriers, but can get into the brain, bind with amyloid plaque, and it lights up. Not the plaque, but the isotope that has found the plaque, so to speak. And you can take a picture of it, a nuclear picture, and you can look at it. And you can say, we see a significant amount of amyloid plaque, or we don't. And actually, the readings these days are binary. Either there's moderate to a lot of it, or there's scant to none of it. So we're not even, I mean, there is research going on, obviously, but the current state is it's positive or negative. And that can be seen on a PET amyloid scan. And for people like myself, it's fairly amazing. These scans are not currently, they're commercially available, but they're not covered by Medicare at this time. However, I'm involved in a study that's sponsored by Medicare and the American Academy of Radiology and some other stakeholders, the radioisotope makers and so on and so forth. Basically, they want to see whether there's the utilization or is rational, whether they should pay for it. So we are getting people free PET scans that would otherwise cost about $4,000 if they're in a trial, not a medication trial, but we answer questions. We have to suspect that they have Alzheimer's pathology. We submit information about the patient about what our plan is as a clinician, and they get a PET scan. And then after that, they get they have a swab of their DNA. It's all de-identified, and they match up the positive PET scans with the DNA, and that's the research. That's the scientific research end of things. But the clinician, after the results are known, is asked, "Did you change what you did for these patients?" And they're looking at that. They're also looking at what did Medicare pay for these patients? Was there a lot of high? And again, it's de-identified. They have a number. What expenses was it to Medicare for the folks that had the positive scan or had a negative scan? So they're trying to figure out whether or not they're going to cover it. So stay tuned for that. But that's ongoing right now. They're very safe, very safe. I've been involved in hundreds of people who've had PET amyloid scans, and I've never seen a problem. I'm not saying nothing could ever happen. But yeah, no, it's a good question. The question is, are the radioisotopes themselves risky or dangerous to the patient? And I would say minimally, and it's not something I would ever worry about. And the amount of radiation is way below what you're allowed for a given year. So I wouldn't worry about that part. There's also PET scans involving tau. They're not commercially available, but they're used for research. And in clinical trials, sometimes folks get PET amyloid scans, PET tau scans, and so on and so forth. And PET tau tends to be something that the amount of abnormal tau protein, again, it's abnormal tau, called phosphorylated tau. That's more quantitative. So the more there is, perhaps the farther along you are in the disease process. So there's PET tau, PET amyloid. There's also something called cerebrospinal fluid markers. So if anybody's ever heard of a lumbar puncture or a spinal tap, most people are terrified of this. I used to do these, but basically blindly as a resident in the middle of the night. Now you can go to an X-ray, get a fluoroscopy. People see exactly where they're going and withdraw the fluid. So there's sort of an outsized fear of these. But the point is, you get the fluid and you look for markers of abnormal tau and amyloid ratios, and those are biomarkers, actually excellent biomarkers. And finally, there's now blood tests. In Europe, they've been used widely, and there's actually 2 blood tests now comparing the ratio of different forms of amyloid that can be supportive of a correct diagnosis. So I wouldn't randomly going about, and those still are being looked at. The sensitivity and specificity, how good these tests are, they're pretty good, but they still need some more work and some standardization. So the point of these biomarkers that I would like to make is that I wouldn't randomly do them. I don't see the utility in that. But if it's somebody that we suspect has a problem and we utilize the biomarkers and it doesn't support our clinical diagnosis, then let's take a step back and think about things. And once in a while, you do get a surprise. Once in a while, you do get a surprise. So the question is about the inheritance of Alzheimer's dementia. Excellent question. There's basically, I would say, 2 major categories. That's debatable, but for purposes of our discussion, we'll say 2 major categories. The run-of-the-mill, and I don't mean to diminish the seriousness of the disease, but the run-of-the-mill type of Alzheimer's dementia. Somebody's 80 years old, they have Alzheimer's disease, your mother had it at 80, your father had it at 80, you're concerned for good reason. Those folks have approximately 10 to 30% higher risk than the general population of developing Alzheimer's disease. So it's not, it's not great, but it's not the worst ever, right? And if you live long enough, probably by age 90, over 50% of the people have some form of dementia. A lot of times it's Alzheimer's. The other thing is there are, and this gets a little bit more granular and esoteric, but there are families that have autosomal dominant genes. Genes meaning, autosomal dominant meaning you just happen to inherit one specific gene to get Alzheimer's disease. And these are sort of pockets of family throughout the world that have been studied, and they will have signs of dementia in their 40s even. But thank God that is not the norm. And in fact, Down's syndrome folks get Alzheimer's dementia in their late 30s, 40s sometimes. So that connection is being studied. I'd like to move on, and it's a kind of a serious subject, but I'd like to offer some hope. And I'm going to bring up Rebecca in a moment. And we talk a lot about serious things, and we don't have any disease-modifying therapies, things that will slow the progression down. And that's always been what's bugged me. I can make a diagnosis, I can tell people some practical things, but what can we actually do to offer hope? Because it can be pretty depressing. And I'm going to just take a step back and talk about another disease process as I lead up to this. In 1993, when I started medical school, there's another disease that you may be familiar with called multiple sclerosis. Okay, in 1993, we had no medications for this whatsoever. If somebody had a relapse, they were put on steroids, just to simmer the process down. There was nothing we could do to change the course of the disease. Today, in 2022, there's approximately 22 medications for multiple sclerosis. Not cures, but medications that can greatly and positively affect the course of the disease. And so in my career, which isn't over yet, I've seen this paradigm shift where, geez, you have diseases that you couldn't do anything about for hundreds of years, and now you can. So I'm hoping to accomplish this or be part of the team that accomplishes something similar with Alzheimer's disease. And let's start with slowing it down. That's the first goal. Once that's achieved, let's move on to stopping it in its tracks. And then the third process would be actually to reverse it. We're not there yet. We're still working on slowing it down. How are we going to do that? Through clinical trials. Okay? And they offer hope. Let me just tell you a little bit about clinical trials, and I'm going to have Rebecca, who works for me at Advanced Clinical Institute in Neptune as a research coordinator, tell you a little bit more about the nuts and bolts of what a volunteer would go through in a clinical trial. But let me tell you a little bit about what it is. It's a research study that tests a medicine or a therapy in human beings. And you may hear them as clinical studies or clinical research. And these help us answer questions, particularly does a medication slow down the progression of Alzheimer's disease? That's what we're interested in. And the volunteers, and it's completely voluntary, obviously, it has to be, are people that I consider medical heroes. They're folks that want to fight back, that want to do something, they want to contribute, they want to have hope, both for themselves. Not every trial works, a lot of trials don't work, but we learn from each trial. If something didn't work, we learn something from it, and we apply it to the next one. So I'm going to leave it right there, and I'm going to have Rebecca come up, and I'll be here for some questions as well.
So the first thing to discuss with clinical trials, at least from my end on the coordinating and for the participant, would be a study partner. You'll hear that term used interchangeably with caregiver. This is someone who sees the participant a majority of the week and knows them well. They attend visits with the participant, and throughout the trials, they will have assessments that they participate in where their answers are then compared against the participant. Each study has a unique set of inclusion and exclusion criteria. This means each trial has different things that they allow for entry. These are based on a subject's age, current medications they take, and when they started them. Most sponsors would like for you to be on a stable dose of 90 days before entering a trial. This also has to deal with your current medical condition. So for example, diabetes, high blood pressure, things of that nature. They also will look at past medical events of the subject, such as surgeries or hospitalizations. And they do want to know about your lifestyle. Are you in the state often? Do you travel? Do you drink often? Do you smoke? Are you a former smoker? So they take all of these things into consideration when building a clinical trial and setting up what they allow for entry. There's different types of trials. Specifically at our clinic, we have pills or tablets. We have infusions that range from an hour long to 2 hour long. We also have injections. Now, each clinical trial is very unique in how it's set up. For all that was just mentioned, there's different lengths for how long the trials are. Some are a year, some are over a year, some can go up to 3 years. Each trial will start with a screening period. Some are 2 months long, and some are a little over a month. And the screening period is very important because this is what's going to determine if you are entered into the trial. What happens during the screening period is as follows. First is informed consent. Informed consent is extremely important. It lays out the schedule of events for the trial. It lists what's expected of the participant and the caregiver. It also lets the patient know the risks to them, so what they can expect that might happen. When signing the consent, present are the witness, the PI, which is the doctor on site running the trial, the subject, and the caregiver. And it's important to note that even if you sign consent, you can withdraw at any time from a clinical trial with no penalties. Also during a screening period, we have cognitive assessments that are done with a PI and a rater on site. There are safety assessments, vitals, which include your blood pressure, pulse, weight, height, and temperature. We also do electrocardiograms or ECGs. Those are non-invasive electric tracing of your heart rhythm. We also do blood work. We want to know how's your sodium, how's your glucose, how are we doing with all that. There's also brain images, as Dr. Greenberg spoke about, MRIs and some PET scans that can be the amyloid PET or the tau PET. A big question I get asked when I do these presentations or even when patients call in is, what is the expense? What does a clinical trial cost to me? And the answer is honestly just your time and your patience. Everything is covered by the study. Nothing goes through your insurance, and nothing is at cost to the patient. Most sponsors will also have travel covered, meaning we will provide transportation if you don't want to drive. We can set up rides and all of that. Also, there are stipends for participating, and the amount varies for studies, so I can't really ask how much because it all determines on which study a person enters, but there's stipends for the participant and the caregiver. Another major question I get asked is, are clinical trials safe to me? And in my opinion, and many others, clinical trials are extremely safe. It's different than going to your primary caregiver. There is a whole clinical team, whether it be me, the doctor on staff, the nurses on staff, the psychologists on staff, that are dedicated to monitoring the patient's health and wellness. Monthly, you can expect what we spoke about in the screening period, blood workups, ECGs, which are the non-invasive tracing of the heart rhythm, vitals. You're probably going to get sick of someone taking your blood pressure. We also do cognitive assessments, which kind of let us know where the patient's at. Also on site with the doctor, there is physical assessments and neurological assessments. In our experience, the studies, our patients do very, very well, and there's seldom any problems or issues. We encourage our patients to connect with the clinical staff at any time with any concerns, because our main goal is to keep you safe. I think the biggest thing to take away from this is that what Dr. Greenberg said, these are medical heroes. So yes, you're putting things on the line, but we're also there to help you and be in your corner and root for you, and we want to see you do well, the patients and the caregivers. So with that, I would like to say thank you for allowing me to speak with you today, and Dr. Greenberg and I would love to answer any questions that you may have.
We do have some flyers up here with our contact information for anybody here, or if they have friends or loved ones. And just for the outside audience, our name is Advanced Clinical Institute. We're in Neptune, New Jersey. If you email info@ACI, Apple, Charlie, Isaac, ACINeptune.com. info@ACINeptune.com. We'll put you in touch with Rebecca. If you want to look on the website, it's ACINeptune.com. And the phone number is 732-807-4700. So if anybody has a friend or family that's interested or might be a candidate, we encourage you to call, email, and come down to discuss, free memory screen, and so on and so forth. You can also talk to your clinician or physician, primary care physician, about clinical studies. Not every clinician knows that much about it, frankly, but you can certainly bring it up. And then I'd like to make one last comment about the Alzheimer's Association in the state of New Jersey. I happen to be on the board of the local chapter, and it's a very fine institution. They do a lot of good work, and there's actually a helpline. Well, first I'd ask you to get on the website alz.org. There's a lot of information about caregiver support, research, practical information, and there's actually also a helpline, not a medical emergency helpline, but a helpline for those in need. And the Alzheimer's helpline is 800-272-3900. 800-272-3900. And I just want to acknowledge that the caregivers for Alzheimer's patients go through a lot. They're often elderly, may not be in great health themselves, and need a lot of support. And I think a good place to start would be in the Alzheimer's Association. Thank you.